Well, good evening and welcome everyone. Thank you so much for joining us for another Wellness Webinar Series event with Jefferson Health. My name is Sarah Breckbill and I will be serving as your program facilitator and will present your questions to our panel of experts. This evening, Jefferson Health experts in OBGYN will answer your questions from bump to birth. Well, thank you so much for submitting your questions in advance. And the questions that you will hear me asking the providers are all submitted questions right from when you registered for this webinar. If you have any additional questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you will see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital university guidelines and privacy, we are unable to comment on specific cases. Likewise, if you are experiencing any symptoms that may require medical attention, please consult a medical professional. Finally, don't worry, we've taken the liberty of muting everyone's line to eliminate any background noise, so feel free to move around and get comfortable. So with that, I would like to introduce our experts for the evening, starting with Dr. Maritza Martinez, Obstetrics and Gynecology, Dr. Juliana Choi, who is a certified nurse midwife, and finally, Dr. Janet Ko, Obstetrics and Gynecology. Well, thank you again for joining us this evening. And to start things off, I'll give each of you a minute or two just to say hello and maybe give a little bit of background about yourself, and then we'll go ahead and dive into the questions. So Dr. Martinez, we'll go ahead and start with you.
Hi, I'm Dr. Martinez. I'm an OBGYN at Jefferson Abington OBGYN. I've been there for 22 years. I trained at Abington and joined a private practice right after that. I've been with the same practice for 18 years and am really, really happy. I have 3 kids and I grew up in Los Angeles.
Wonderful. Well, thank you so much.
Yes.
All right. We're excited to have you. I think it's going to be a great discussion. Juliana, we'll turn to you. How are you this evening?
Hi, thank you, Sarah. I'm so happy to be here and excited to be part of this event. My name is Juliana. I'm one of the now 10 certified nurse midwives we have at Abington. We have a growing and thriving midwifery group here. I just joined the team here at Jefferson last September, so I'm a newer member, but I'm thrilled to be starting my midwifery career here. Prior to this, I have experience working as a labor and delivery nurse in New York City, and I was born and raised in Portland, Oregon.
All right, well, welcome and thank you. And finally, Dr. Ko, thank you for joining us this evening. How are you doing? Oh, I think you're on mute. It happens to all of us.
I'm so sorry, the first technical difficulty. I'm so happy to be here. I thank you all for joining us, and I hope that we all provide you with some really helpful information. I'm Janet Ko. I'm an OBGYN here at Einstein Montgomery, which is out in East Norriton. I practice both obstetrics and gynecology. I've been in practice for the past 21 years now, first mainly at Einstein Philadelphia, and now here at Einstein Montgomery, where I'm now serving as the chief of the department here. I actually have no children, and I grew up in North Carolina. I have no children, so I live very vicariously through my patients and friends and family that do. So I hope you have a really wonderful evening tonight, and hope we can really talk about some great information tonight.
All right. Well, thank you so much. And without further ado, I think let's just go ahead and dive right into the questions. Again, I know it's going to be an exciting discussion and we're certainly going to learn a lot. So Dr. Martinez, we will start with you for our first question of the evening. What is the best way to track your fertility window?
So it's a really common question and actually kind of easy to do. It just involves tracking your period. So basically, I recommend getting an electronic calendar or a paper calendar. I still use paper calendars and that's okay. And you want to do this for about 3 months, and you start numbering your calendar on the first day of your period. So that's number 1. And then you just, each day you give a number, 1, 2, 3, 4, 5, etc., until the first day of your next period, which is the number 1 again. then most people have a cycle length varying between 24 to 35 days, and that's very, very, very normal. And you can find out when you ovulate by basically subtracting 12 to 14 days from the first day of your period. So if you have a 28-day cycle, then you subtract 12 to 14 days from that, and you basically ovulate about day 14 to 16. And that would be your fertility right around the time that you would ovulate. So if you have a 24-day cycle, then you subtract 12 to 14 days from that, and your fertility window now is day 10 to 12. And the same thing with a 35-day cycle. You're going to subtract 12 to 14 days from that. And so you're going to ovulate a little bit later. I recommend that you have sex about 5 days before this time, and through ovulation, and for a day afterwards. So it's about 7 days that I recommend having sex. You could do it every day. You could have it every other day if it's a lot, and basically that's it. So it's a total of about 7 days. You could also, to confirm you're ovulating, you could also check to see if your vaginal discharge has been thinner right around the time that you're estimating you're ovulating. So vaginal discharge changes throughout our cycle, and right around ovulation, it should become a little bit thinner and clearer at that time, and a little bit more in volume. So kind of like egg whites, which we always use food metaphors. I don't know why. And if that's still, if you're still unsure, then there are ovulation prediction kits, which tell you if you're ovulating by measuring the amount of luteinizing hormone in your urine. And this, usually you have a luteinizing hormone spike about a day before you ovulate. So you can kind of figure out when to have sex a little bit more precisely. Not as reliable if you're having irregular periods.
Okay, well, thank you. And a great segue into our next question there. Dr. Coe, I guess for those who are not getting their periods monthly, is it possible to ovulate, and is it more difficult to conceive with irregular periods?
Yes, it can certainly be a little bit more difficult to predict ovulation. As Dr. Martinez described just now, predicting your ovulation is really based on counting the days in your cycle and having a fairly regular, predictable cycle. So if you are someone who gets sort of an infrequent period, you're skipping your period here and there, you're getting them a few months apart, or even there are people who never get their period, they might go for more than a year without a period, it can definitely make it hard to predict when ovulation will occur, because you really don't have any basis to count backwards from or forwards from either. Now, the caveat to this is that it's certainly, we rarely tell a patient that if they fall into this category of irregular, infrequent periods, it's not impossible to get pregnant though. So we certainly get patients who unexpectedly get pregnant because they assume that they're not ovulating. But it certainly makes it a little harder to plan ahead. Like if you're planning to try for pregnancy, it's hard to predict when your fertile days are. It also brings up, when someone has infrequent cycles or an irregular period, it brings up the more important question of what's the underlying cause of this? Is it a hormonal problem? Is it polycystic ovarian syndrome? Is it perimenopause? There are many, many conditions, diabetes or anatomical problems, other hormonal problems that can all contribute to having an irregular menses. So I think that when someone presents with this, part of our job is to try to figure out what the underlying cause of this is.
Okay, well, thank you so much for detailing and walking us through that. Very helpful there. All right, moving along to question number 3. Juliana, can someone become pregnant even if ovulation tests do not show you are ovulating?
Yeah, so The short answer is yes. I'll dive a little more into what ovulation tests are and, some of their pitfalls. But, Dr. Martinez mentioned ovulation tests detect. So first of all, they're very similar to a pregnancy test. You can buy them, at a drugstore. You do, the urine sample right on the stick. And they're actually detecting this sudden increase in the luteinizing hormone, or LH, your LH surge. And that tells you that ovulation is likely to occur in the next 24 to 48 hours. So it's giving you that prediction of, you're entering that fertile window. So this can be a really helpful tool when trying to conceive. And when used correctly, ovulation tests are 99% accurate in detecting that LH surge. But there are a couple scenarios where you might get a negative ovulation test, but still conceive. And this would be with what's called a false negative test. So a case when maybe you do have an LH surge, or you did have an LH surge, it just wasn't picked up on that test. So this might happen if the test is used incorrectly. So, really good idea to read through those instructions and make sure you're doing the test correctly. If your urine is too diluted, so it's possible if that urine is too dilute, it may not pick up enough of the LH in the sample to trigger the positive on the test. And also if your LH surge was really short or brief and you actually missed it with testing, that's why it's a good idea to actually take the ovulation tests twice a day around that expected time. So overall, they're, a great tool and they can be really helpful. But just, like Dr. Martinez said, tracking those cycles, getting a sense of what your personal, cycle length is, making sure you're testing around the same time and using those tests twice a day to really maximize the accuracy.
Okay, thank you so much. All right, moving along, let's talk now a little bit about nutrition. Dr. Martinez, any suggestions for pre-pregnancy supplements or nutrition recommendations to support conception and also leading up to pregnancy?
Yes. So the most important supplement we recommend is folic acid. It helps prevent neural tube defects, and these are just disorders of the brain and spinal cord. The brain and spinal cord do develop in the first 6 weeks of pregnancy. So actually, even before you're pregnant. So folic acid will help prevent these. And you want to take about most persons need about 400 micrograms per day. Prenatal vitamins, over-the-counter prenatal vitamins have 800 micrograms, and prescription strength prenatal vitamins have 1,000. You do need 400 micrograms, so over-the-counter prenatal vitamins are just fine. The only group of people who do not who we recommend more folic acid supplementation ahead of pregnancy are those persons with a history of a child affected with a neural tube defect, such as a child with spina bifida or anencephaly. And we recommend 4,000 micrograms of folic acid in the first trimester. And in terms of nutrition, as always, I recommend a really great balance of fruits, vegetables, lean proteins, beans, legumes, or anything like that. Yeah.
Perfect, thank you. And just a quick follow-up question there. Is it best to start these prenatal vitamins prior to conception?
So yes, we highly recommend that you start it beforehand. As I said, everything kind of develops in the first 6 weeks of pregnancy. So even before you're pregnant. So starting a folic acid supplement or a prenatal vitamin about a month before you want to conceive is the best course of action.
Okay, great, thank you. All right, Dr. Ko, turning back to you, would you recommend any form of genetic testing prior to getting pregnant? What if the birthing parent and her partner doesn't know their biological parents?
So, I think that ideally everyone should consider preconception counseling if they're eventually planning for pregnancy, and that does include a detailed genetic history. And when I say preconception counseling, it could be something so straightforward as, your next OBGYN routine visit, just mention casually, oh, maybe the next year or so we're going to plan on trying for pregnancy. But I also realize that not everyone fits into that category, so it should be something that people consider, but it's not always practical to have that done. If someone is really planning ahead, I think the smart thing to do about considering genetic testing and genetic histories is they should try to ask their family members about their own health histories. A lot of people don't know details about their own family members until they start asking questions. And if you think about it, people who start to, who enter into early adulthood, like, a lot of young adults just aren't told a lot about their older family history, older family members' history. So I think that it's a great time to just start asking. So for example, ask family members things like, hey, are there people in our family that have any sort of genetic problems, any particular syndromes? Things like, some of the well-known syndromes that I think generally most people have heard of are things like Down syndrome, sickle cell disease, things like that. And those are questions that can be asked to most people. Other questions that you can ask family members are things like, did we ever have any babies that were born within our family that were born with birth defects, or any problems that were diagnosed at birth? And you'll be surprised sometimes at some of the information that you can gather from that. If any of these things are positive, then what we do as an obstetrician is we go over any sort of particular patterns that stand out, any particular syndromes, or any particular coincidences that we see, and we talk about whether there is any sort of preconception testing or screening available for that. And the great thing is we have the use of genetics counseling available to us in order to consult with them. We look at patients' family history, like I just mentioned. We look at what their ethnic origin is. And sometimes patients will just ask and say, hey, I would like to be tested for the common things that are out there. So for example, so when I mention about patients, someone's ethnic origin, so for example, there are absolutely certain genetic diseases that tend to run in certain groups of people. So for example, Ashkenazi Jewish population has a higher incidence of cystic fibrosis, Tay-Sachs disease. The Irish population has higher cystic fibrosis. The African or Mediterranean population has a higher incidence of sickle cell disease. So we may make some recommendations based on that. But nowadays, we're also doing things like expanded carrier screening, where we actually don't take someone's race or ethnicity into account because in this day and age, there are many, many, many people who have multiracial, multi-ethnic backgrounds, and it's not possible to really parse out who, what percentage is of one race or ethnicity, and what does that actually mean. So this actually, when we look at that, when we do sort of an expanded screening where we test everyone, we offer the expanded testing to everyone. This will take into account situations where your family history is unknown. Maybe you just don't have contact with your family, or maybe you were adopted. Maybe you were raised by people who are not biologically related to you. So that sort of takes that situation into account. I said in the very beginning, this is a suggestion. It's not something that we tell our patients that they absolutely should do all of this genetic testing. It kind of depends on your approach. It does allow what are the pros and cons of genetic screening and genetic testing? It gives the patient autonomy. So the patient, when they know the results of their genetic tests, they have control over what their reproductive decisions are, and they make future decisions that might be influenced by what their testing results are. Potential harms, though, testing, what if you test positive for something that is really not that severe and really wouldn't matter to you in your life? What if you knew you were positive for a cancer-causing gene, but you know what, you wouldn't get this cancer until you're 85 years old? Would that say to you, like, well, I don't want to have children because I might pass that risk on to my child? Is that a deal breaker for you? And sometimes these test results come out with uncertain results. Like sometimes there are genetic mutations that we test for and you know what, we don't really know what they mean, what they really mean to you in the future, because we don't know enough yet. There's very extensive testing available, which is wonderful because we're constantly learning about new genetic mutations, but we don't really know what to do with all of them, you know, every single one of those tests. So the bottom line is we have the testing available, we have the screening available, and then it's really up to the individual to decide whether they want to pursue that. So.
Okay, well, thank you so much. And yes, certainly interesting to hear all those options available. So thanks for going through that. Okay, Juliana, we'll turn to you. What doctors or specialists does someone need to see before getting pregnant? And how long before trying to conceive does a patient need to go off of birth control?
Yeah, great question. So first, what doctors or specialists do recommend seeing? First of all, it's good to see your primary care for your annual wellness checkup. You know, they'll do that physical exam, any routine lab work you need, and just generally help optimize your health as you prepare for pregnancy. Also, one people tend to forget is to get your routine dental cleaning and dental checkup out of the way as well. If you are someone who has any chronic conditions, it's a great idea to see a specialist for that condition, and to let them know that you're trying to conceive. You know, any chronic conditions, ideally we want to be well managed before entering pregnancy. So for example, just some of the common ones we see, if you're someone with diabetes or a thyroid disorder, seeing an endocrinologist. If you're someone with high blood pressure, seeing a cardiologist. Someone with migraines or a history of a seizure disorder, seeing your neurologist. So just some examples, some of the common things that we see. Be sure to mention again that you're planning to become pregnant, so they can ensure that any medications you're taking are going to be safe and compatible with pregnancy. And then it's always great to research and find an OBGYN office if you're not already established, and to come see us for a preconception visit. So we do recommend coming to see us at least a couple months before starting to try to conceive. It's a great time to establish care with an OBGYN or a midwife if you haven't already. You can complete your pap smear if you're due for that. And as Dr. Ko just discussed, it is an option to do the genetic carrier screening beforehand if that's something that you desire. And it's just a great time to get some kind of anticipatory guidance about your pregnancy care and what things will look like moving forward. The second question, when to stop birth control? In general, you should stop birth control when you're ready to welcome a pregnancy. Luckily, most forms of hormonal birth control, so the pill, the patch, the vaginal ring, the IUD, the Nexplanon arm implant are all short acting. So these hormones are going to be out of your body pretty quickly after you stop. Most people do return to their normal cycles within 1 to 3 months of stopping the birth control, but it's possible to conceive within that first cycle. The only form of birth control it's good to know that is a little different is the Depo-Provera shots. These can take, once you stop, can take a little bit longer to return to your cycles, sometimes up to 6 to 12 months. So that's definitely something to discuss with your OBGYN or midwife if you're planning to try to conceive soon.
Okay, thank you so much. Appreciate it. All right, moving along, but before we get into our next question, we're seeing a lot of questions come in from you all, and we appreciate it. We will definitely get to those at the end, so feel free to keep sending in your questions, and we'll certainly continue to keep an eye on those as we move along here tonight. But before getting into the live questions, we still have a few more questions to get through that you first submitted. Dr. Martinez, we will turn to you. A big question for you here. On average, how long does it take to conceive?
Well, a lot of people ask that, and it could take about a year, actually. It seems like forever. But good news is that about 80% of couples will conceive by 6 months if they're having regular sex. and an additional 5% will get pregnant by 12 months. So it pays to be patient. And I also recommend that if you are less than 34 years of age, to give it a year. And if you're 35 years old to 39 years old, then come see us after 6 months of trying. It could, we could run a few tests at that age, and see if there's something going on that's preventing you from getting pregnant. And if you're 40 years old, then we usually recommend that you come in and talk to us about any testing like Dr. Ko talked about, and make a plan about how long we're going to wait for you to spontaneously conceive.
Hey, thank you. And a nice follow-up question there for you, Dr. Ko. Are there tests that can be done before hitting the 1-year mark of trying to conceive?
So I think that I can probably speak for the three of us when I say that it's a very common question that patients will often come for their regular checkup and they'll say, oh, I just want like some sort of test. I want to know that is my reproductive health optimized? Am I able to get pregnant? And sometimes they'll say, oh, are you trying to get pregnant now? Are you nervous about something? And the very common question is, well, no, I just want to know if everything is working well, and if there's a test that can tell me that, like that's what I want to do. And obviously, I think that's human nature to feel that way. And unfortunately, there really isn't one particular sort of one size fits all test, because as you can imagine, there are a lot of complexities, a lot of things have to happen in order for someone to get pregnant. So in general, Dr. Martinez alluded to this already. We do have guidelines for, timing and how long someone has sort of been trying for pregnancy. And the general guidelines are that if someone is under the age of 35 and they've been trying for a year of regular unprotected intercourse, then at that point, after a year, we should really consider doing an infertility evaluation. For women above the age of 35, we use a 6-month cutoff. And for women who are above the age of 40, we actually use a less than 6-month cutoff of regular unprotected intercourse. And it's not set in stone because we have to consider all the other factors that come into play. So for example, if we have a patient who has obvious risk factors for infertility, let's say that the patient had, let's say you had a history of cancer and went through chemotherapy, radiation treatment, maybe they had endometriosis, maybe they had ectopic pregnancy in the past and they are missing a fallopian tube. Maybe their male partner has a history of genital injury. Maybe they had trauma. Maybe they had mumps as an adult. Maybe the partner had chemotherapy or radiation therapy, because we shouldn't ever forget that the sperm is an equal part of the equation, just like the egg is. So that's why we leave the guidelines. Yes, we have time frame guidelines for when a patient should get an infertility evaluation, but we also leave a little bit of leeway in there so that we can take those factors into play. As far as specific testing, there's a very broad range of testing. So some of the basic testing can be things like, in the beginning, semen analysis. An evaluation of the fallopian tubes to make sure, are they blocked? Are they working? Sometimes that involves like a special type of X-ray. It involves laparoscopy, sometimes a minor surgery to look inside the pelvis. It involves an evaluation of the uterine cavity. And then there are really an endless array of various blood tests that can be tailored to what the individual's risk factors are. So there's just a very broad range, and that is basically the long answer to why there isn't one easy test to determine, whether someone has normal fertility or not. So.
Okay, and a question to that: can someone increase their fertility? Is that possible, and if so, how?
I think in general, And again, Juliana and Dr. Martinez have talked about this already. We try to encourage to try to maintain a healthy weight, try moderate exercise, because surprisingly, actually severe forms of, if you're sort of at the extreme end of exercising, that can actually decrease your fertility, because if it alters your body fat ratio in sort of an extreme way, that can alter your menstrual cycle actually. And then to avoid habits like smoking tobacco, excessive alcohol use. Safe sexual practices is really important, because we want to avoid infections, any possibility of infections that can damage the fallopian tubes and damage the uterus itself. And also to be sort of educated and aware of what your environmental factors are. Like, do you have any exposures at work? Do you work in an environment where you're exposed to chemicals or some sort of possible toxins? But I think the general idea is to try, this is the time to try to attain really excellent health, as the best health that we can possibly attain.
Okay, well, thank you. All right, Juliana, we'll turn to you. Can you talk a little bit about what someone might take if they have been trying to conceive for more than a year? So a few steps that you could detail for us. And then also, if you could talk a little bit about the differences between IUI and IVF.
Yes, of course. So I don't want to be redundant with the first question. I think Dr. Ko did a great job explaining, some of the tests and, next steps that we might take when you come to see us for that fertility workup. But just kind of reiterating that it is a really kind of individualized workup. So, the first thing we'll do is, talk to you about how long you've been trying to conceive, get a full medical history, surgical history, ask questions about your partner, learn a little about your lifestyle, your diet, and then really get a good menstrual history as well. And, talk about the frequency and timing of intercourse you've been having, ask if you've been trying ovulation tests, things like that. Just get a full history and then kind of design your individualized workup plan from there. To jump into IUI and IVF. So the main difference, to really simplify it, is the difference between the two is where fertilization of the egg is occurring. Is it occurring in the uterus or outside the uterus? So to start with IUI, which stands for intrauterine insemination, this is an office procedure that's done where a sample of sperm that has been washed and concentrated is placed directly into the uterus using like a thin flexible catheter that goes through the cervix. And this is done timed during that fertile window to maximize success. And it can sometimes be paired with an ovulation induction agent or a trigger shot like Clomid to ensure that it's done at that fertile window. So IUI can be helpful in multiple cases. It can be particularly helpful with male factor infertility, like Dr. Ko talked about, if there's issues with the sperm amount or delivery of the sperm. And it's also useful with pregnancies that utilize a sperm donor. So those are some scenarios where IUI might be a good fit. IVF stands for in vitro fertilization. This is a little bit of a more costly and lengthier process. There's, the first step is the patient will go through the egg retrieval process. So this is where several of those mature eggs are going to be removed from the ovaries using a small needle. Once that egg retrieval process is done, the eggs are fertilized with sperm in a lab, where they form embryos, and then one or multiple embryos are transferred back into the uterus for implantation. So IVF is done for various reasons, some including female or male factor infertility, if there's a concern for passing on certain genetic disorders, and also with those patients who have completed egg freezing in the past and are now ready to conceive. IVF will be the process for that. So, that highlights kind of some of the main differences. There's pros and cons to both ways. There's different indications and reasons why you'd use IUI versus IVF. definitely different cost rates, different success rates based on the situation. And in general, again, a very individualized decision. And it's a great idea to have a conversation with your OB provider if you are considering one of these methods.
Okay, thank you. And thanks for detailing those differences there. All right, Dr. Martinez, we will turn to you. We'll just have a few more questions before we get to our live Q&A. But for right now, could you please discuss PCOS and endometriosis and how it might affect pregnancy and how to navigate it? What advice would you give to women with PCOS and or endometriosis and who are trying to conceive and might not be having success?
So I could talk for hours about these issues. There's a lot to unpack. And so I'm gonna go briefly through each one. And I just want to say that PCOS and endometriosis are extremely variable in symptoms and how they manifest, and each requires a lot of individualized treatment. So I encourage everyone to meet with their OB/GYN provider before getting pregnant to discuss stopping medications, making a plan as to what's going on before trying to get pregnant. With that said, each process affects conception and pregnancy differently. So I'm going to start with PCOS. PCOS is characterized by irregular periods because a person does not ovulate consistently most of the time. About 5 to 10% of women have PCOS, and it's one of the most common causes of infertility. Because a person does not ovulate consistently, it does make it a little bit harder to get pregnant, but it's one of the more treatable conditions for infertility, which is great. If you have PCOS and are slightly overweight, then losing about 5 to 10% of your body weight in the 6 months before trying to conceive helps a lot with ovulation. So like Dr. Ko said, embracing a really healthy diet and exercising, both you and your partner. I always recommend that this is a team approach, does help to ovulate, and the hope is to conceive. And there is some extra testing that we recommend doing ahead of time when you have PCOS before trying to get pregnant. I like to check your thyroid level and a few other things just to see if there are any autoimmune disorders which are commonly associated with PCOS. And when you are pregnant, there is a small increased risk of gestational diabetes, since one of the theories with PCOS is that there is some insulin resistance associated with it. So many of us do tend to screen a person a little early in their pregnancy for gestational diabetes. Other risk factors when you're pregnant with PCOS include preeclampsia, which is an elevated blood pressure during pregnancy. And because of the insulin resistance during pregnancy, you may have a little bit of a larger baby, and that puts women at risk for a C-section. The hope is a vaginal delivery, but those are the small risks. I'm going to move on to endometriosis. Endometriosis is a very different condition, and it too can make it more difficult to get pregnant. However, it has a different process. Endometriosis involves uterine tissue that is found outside the uterus. So it can be found on your ovaries, your tubes, your bladder, and intestines. And these what we call endometriotic implants in your pelvis can cause havoc, and it can cause a little bit of scarring, which causes some distortion of the organs. So it might make your fallopian tube and ovary a little bit less closer together. It makes it a little bit hard for the egg and the sperm to meet sometimes. It can cause the fallopian tube to not work so well. So the embryo has difficulty moving down the fallopian tube and implanting into the uterus. And there are some hormonal problems and a little bit of inflammation that can, and all of these factors can cause a person to not get pregnant. About 30 to 50% of persons with endometriosis experience infertility. So the fact that you have it doesn't mean that you're going to have problems. And, you know, when I trained, I was told you could have a lot of endometriosis and not have that many symptoms and get pregnant, or you could have a little bit of endometriosis and have a lot of symptoms and not be able to get pregnant. So it varies a whole lot. There are treatment options for endometriosis. And there certainly, as I said, about over half of women with endometriosis will be able to conceive on their own. Treatment options for endometriosis include hormonal management, surgery, IUI, and IVF, like Juliana talked about. And I do recommend, you know, talking to your OBGYN ahead of time before trying to conceive, because since endometriosis can be a little bit tricky, I like to actually talk to the specialists about this and make a plan for you. And this is okay. You know, we all need a little help and a little bit of help in certain things. And so seeking out a little bit of help with our reproductive endocrinologist and infertility team is good. It's not a bad thing. In terms of being pregnant with endometriosis, once you do get pregnant, a person with endometriosis can have an increased risk of miscarriage, preterm birth, cesarean delivery, something called placenta previa, where the placenta implants a little bit low inside the uterus, and having a smaller baby. And these all sound kind of scary, but most pregnant persons with endometriosis will be just fine. They do great. The hormone that maintains a pregnancy is progesterone, and this helps to keep these endometriotic implants quiet during pregnancy. So the hope is that you feel a little bit better once you're pregnant and everything kind of goes smoothly. The only other, if you have some scar tissue, that's the only part that's a little bit tricky during pregnancy, is that it may be a little bit more painful. And for this, I usually recommend stretching and prenatal yoga and some of these other exercises that help minimize these symptoms.
Okay. Well, thank you so much. Some incredibly helpful information there, and you know, really good to hear some of those treatment options that are available as well. Okay, well, just looking at the chat and knowing how many live questions we're getting right now, I think it's time to turn to our questions that you are sending to us right now, so we can go ahead and answer those. So, you know, providers, feel free to chime in if you have any answer to any of these questions, but I will go ahead and just kick it off. And again, audience, thank you so much for these great questions. Okay, so the first question, and Dr. Ko, I think this one might be for you, a question that we had lined up. So if you want to chime in, feel free. This person is wondering, what can I expect at the first 8-week appointment? Do you typically get an ultrasound at this appointment? And if not, when does that usually happen? And what is the process for that?
Okay, so yeah, so the initial visit for a new prenatal appointment, ideally it's in the first trimester. So anytime, first trimester is technically up to 12 to 14 weeks. Ideally that should happen, you know, pretty much, you know, as soon as you find out you're pregnant. Most people will call the offices and get in for a new prenatal appointment. The new prenatal appointment, I think, sets the tone for both the patient and also for your prenatal care provider, if it's your midwife, your obstetrician. The most important part, I think, is to establish that relationship, get a really good history. So to be able to identify any concerns that need sort of extra attention or extra monitoring throughout the course of the pregnancy. So normally what happens, and certain practices may do this a little bit differently, is, sometimes a patient will have like sort of a meet and greet and appointment and the very beginning to sort of get to know the practice and get as an introduction to the practice, where the and a history is obtained, and then it can determine, that visit will determine what blood work is needed, whether it's just your routine basic prenatal panel or are there additional tests that need to be done. And then it also can identify, well, how early should you have an ultrasound, right? So many practices will do will try to do an ultrasound at that first visit, but it really depends, because if you're only about 4 to 5 weeks along, then an early ultrasound may not be very helpful because it's just so early. So if you're a little bit further along, 8 weeks plus, maybe that will be done at the office. But that's sort of I'm not going to say there's like one blanket answer for that, but that initial visit is really important. It really sets, it's our opportunity to make a plan with our patient on sort of the course of the pregnancy and what to sort of expect. So.
Okay, thank you. And then another follow-up question for you. Another audience member had this question, and I think this relates nicely. How early can I call my doctor after a positive pregnancy test? And whoever wants to chime in here, feel free.
We usually get people who call right away, which is great. And we actually don't mind. We at our practice, we do what we call a new maternity telehealth between 5 and 7 weeks of pregnancy. So calling when you have a positive pregnancy test, we set you up for that. It's a 30-minute talk, as Dr. Ko said. We talk to you, we get your history. We do a lot of counseling, a lot of education, and figure out what labs you need, and also set you up for your first ultrasound. So, we're great with having you call right away.
Awesome. So the sooner the better. Sounds good. All right. Next question. Does the first day of the cycle mean any bleeding or even spotting? This is in relation to tracking periods. So Dr. Martinez, if you want to take this one.
Yeah, so I usually recommend, a lot of us have a little bit of spotting right before our real period. And so I like to say when you have more of a flow. So, you might have a few spots of blood one day, and then like 1 to 2 days later, you have a regular flow. So I kind of consider the regular flow a day one.
Okay, good to know. Thank you. All right, next question. What might be the cause of getting negative ovulation tests for a week during your fertile window?
I guess to reiterate from my earlier question, there is a possibility of a false negative. So, going back to the packaging, making sure you're taking the test correctly, using that first morning urine that's going to be more concentrated. So making sure you're not, drinking tons of water and then taking the test right after. So your urine's not too dilute, and then taking it, twice a day, as well as, making sure that you have been tracking your cycles and subtracting those 12 to 14 days from your total cycle length to make sure you're doing it right around the right time. So I know it's a little redundant, but that's what I can think of. I don't know if anyone else has any thoughts on that.
No, I think that's great.
Thank you. Perfect. Another follow-up question there. So we'll keep this theme going. If you don't have an LH surge multiple months in a row, should you be concerned? And whoever wants to chime in, feel free.
I would say, come talk to us about it. Maybe we do have to check some labs, and we have to figure out what your cycle's doing, and to get a better picture of what is happening with your body. We may order an ultrasound to look at the thickness of your lining in your uterus. So there are many reasons why you might not have an LH surge in a regular cycle. So I think, yeah, if you're not seeing that for about 3 months, then come see us.
Okay, great. All right, Dr. Martinez, another question for you. Know you mentioned earlier in our discussion about the importance of taking folic acid, and this person is interested in folic acid versus folate. Do you have any comments there?
Well, folic acid is folate. I know there's a little bit of a difference, but it's just the amount that you want of each that you want to take. So 400 micrograms of each would be great.
Okay, perfect. All right, moving along here. Again, thank you all for your wonderful questions. Such a terrific discussion. Okay, our next question here. How long does it take for your period to normalize after the IUD?
So it should be pretty immediate. With a copper IUD or the Paragard, that is the non-hormonal IUD, so that, that shouldn't really be affecting your cycles in the first place. You should continue to have your normal cycles. With the hormonal IUD, like the Mirena or the Liletta, like I mentioned before, those hormones are really short acting, so they should be out of your body very quickly, and you should return to that normal cycle within a couple of months. If you haven't had a cycle return at all in, say, 2 or 3 months, that would be a reason to come and chat with us.
Okay, great, thank you. All right, Dr. Ko, question for you here regarding medications during pregnancy, specifically antidepressants and mood stabilizers. How do I know what is safe? This person is wondering. Oh,
that is a great question, especially in this day and age. Just as a statistic to throw out there, in this day and age, about 8% of our pregnant population in the United States are taking some sort of antidepressant medication. So it's very, very, very common. So these are really common questions that patients come to us with. The most common antidepressants are the SSRIs. It's a very common class of medication that we use for antidepressant and other mood disorders. And the common names for those are things like Prozac, Lexapro, Paxil, Zoloft. These are very commonly used. So when this category of medicine first came out, as always, we always want to be very careful with medication use in pregnancy, but at the same time, when we think of any sort of medication use in pregnancy, you always are balancing the risks and the benefits. So if it's worse for someone to not be on a medication, and stopping a medication because they're worried about the effect of pregnancy also results in really poor health for the mother, then that is not a good situation. So we've had now many, many years of experience with the SSRIs, the most commonly used antidepressants. And so the good thing is we have a lot of data out there. And it's, initially when they first came out, we were concerned, there was some concern about higher risk of cardiac defects, things like that. And now as the years have gone by, when you look at the numbers overall, that category of medication is not considered a major teratogen. Teratogen is basically any medication that is directly causative of some sort of birth defect. So that question back in the day, there was a question about increased risk of cardiac defects. So there are a lot of studies out there, and sometimes it's confusing because some of the studies will show that there's a slightly higher risk, and then others will show that there's not an increased risk. Other questions that patients want to know is, does this increase my risk of miscarriage? Any of the medicines that I'm taking, the SSRIs, they've also looked at things like, does it increase diabetes? Does it increase risk of earlier birth, hypertension, things like that? And, it's a little bit unclear, but it's unlikely to have a significant risk effect on those risks. One of the things that we may see, though, in sort of day-to-day in our obstetrical lives is that at the time of birth, sometimes newborns might have slightly decreased APGAR scores. So that's that score that babies are given within the first few minutes of life, and it's based on their color, their breathing, the degree of crying, things like that. So sometimes some of the babies where moms have been on one of the SSRIs, they might be noticed to have a slightly slower transition. But what does that mean in the long run? It's probably not significant. The bottom line is that when you're thinking about any sort of medication, it's, in order to have, most obstetricians use the guideline of, in order to have a healthy pregnancy, you have to have a healthy mom. And if medications are part of helping to have a healthy mom, then we are absolutely in support of that. One of the things that we are actually a little bit afraid of are when patients find out that they're pregnant and they haven't gotten in to see us yet, and they get very nervous about their pre-existing medications. So it's very common that we see sometimes patients will abruptly stop their medications because they are worried about potential harmful effects. And so it's hard. That's that sort of vulnerable period of time. So that's when, again, in an ideal world, that's when it would be ideal for patients to come see us early in the game, so we can sort of have that conversation about which medicines are safe to take and which ones are really important to continue for maternal health, really, as well as fetal health. So.
Thank you. Yeah, certainly important. Sounds like for moms to prioritize their health. So having that conversation is definitely necessary. So thanks there. Okay, a quick follow-up actually along those lines. This is more so looking at, this person wants to know if it's safe to take natural or herbal supplements such as turmeric or dandelion root prior to conceiving, knowing that one is trying.
So I'm interested to hear also, like, from Dr. Martinez and Dr. Choi and Juliana as well. Everything comes with like a little bit of a caveat, right? Like, so when we're talking about prescription medicines and medications that are regulated by the FDA, those things are regulated. And so for the most part, you kind of, when you buy a bottle of Tylenol, you know what you're getting. And I think that when it comes to herbal supplements and sort of other, the risk that we take is that they're not regulated. You're not really quite sure what dose you're getting, things like that. Now, there are organizations out there that are sort of voluntary organizations that evaluate many of these supplements. So I'm a big believer in, if a patient comes to me with these questions like, hey, I'm taking these supplements, I've read about them, and these are what I think are the benefits from these. If you kind of have to just make the decision together and have a conversation together. And everything is about, in the world of medicine, everything is about risk versus benefit, right? So I'm very much like, if a patient wants to try a supplement, and if it doesn't seem like it's going to be harmful, and if they feel like they're getting it from a reputable source, then I'm not against that at all. I think that sometimes people look at physicians and think that we're only about like very strict, conventional medicine. And I don't think we're all like that. We also are pretty open-minded as long as there's some sort of evidence, or we try to make use of whatever available evidence there is. But there is a lot of evidence about certain herbal medications and certain non-traditional supplements. And I think that if it's not really known to cause harm, and it could potentially help, then I don't really see that there's much of a risk with that. And I think those are discussions that are really nice to have with patients and their providers. So.
Yeah, I agree a lot. I had a patient who was taking a supplement. I think she was from South America, and it helped her with her headaches. And I had to admit that I had never heard of it, so I had to look it up, and there was nowhere in the literature did it say it was harmful. And ironically, she stopped it while I did the research for a week. Her headaches came back, and then I came back and I said, I can't find anything wrong. And so why don't you restart it? And she restarted it. Her headaches went away and she felt great for the rest of her pregnancy. She delivered a healthy baby and everything was fine. So I think it should always be a conversation of risk and benefits. And there are very few supplements that are known to be not great for pregnancy. And then the rest are either unknown, or there's not enough data, or we know that they're okay.
Okay, great. Just the importance of having those conversations with your providers. So thank you. And, along those lines, we have another question here, actually. This person is wondering if there's any good resources supported by up-to-date research available that could be used to check safety of certain food items, medications, health and beauty products, et cetera, during pregnancy, other than maybe your OB and their team, if, just looking for a quick way to check the safety of a product.
One that comes to the top of my mind is Mother to Baby. It's a great website. It mostly focusing on different medications, and gives a brief overview of kind of up-to-date research that we have about that particular medication during pregnancy. So that's a good kind of database to check out.
Perfect. Thank you so much. Okay, we will continue. We're certainly getting all the questions, so thank you. Dr. Martinez, let's turn to you for a minute. This person is wondering, how would you know if you have endometriosis? Is there a test for this, or can it be seen on an exam?
So endometriosis is typically characterized by painful periods, heavy periods, pain between your periods, pain with sex, basically pain, and heavy periods. So if you have these symptoms, then, it is something that you should bring up with your OB provider to see if certain medications help to resolve these issues. The only test that really confirms and that you have endometriosis is actually surgery. So basically laparoscopy, taking a look inside your pelvis to see if that's what you have. Some women can develop something called an endometriotic cyst on their ovary. And so this can be found during a pelvic exam, and then we would do an ultrasound and sometimes an MRI to confirm these findings. But it's not until we actually look at that cyst or open up that cyst can we say, yes, you definitely have endometriosis. On exam, typically we may feel this nodular area behind the cervix, but it's just a suggestion that you might have endometriosis and not 100%. So really visualizing endometriosis is the only true way of saying, yes, you have it.
Okay, thank you. All right. This person here is wondering wants to know a little bit more about male fertility. So what tests, if any, should the male partner take prior to getting pregnant? And what are some health issues that can affect fertility from the male side? Is sperm testing recommended? And whoever wants to hop in, feel free.
Yeah, I think, reiterating general health and wellness going into the trying to conceive period. So, just like the birthing person, the partner should also be seeing their primary care, getting all those routine labs and checks done. Just, general health and wellness, like we talked about before, exercise is great to actually boost your fertility as well. And, following a good balanced diet. As far as the sperm analysis, it's definitely not something that is routinely needed. If there's some concern, like Dr. Ko alluded to before, if there's some concern and based on history, then it's definitely something that can be talked about. But I wouldn't say it's a routine test for everyone.
I don't know if either one of you two do it, but when I see a patient for an infertility workup, I actually do tend to do a sperm analysis. In addition to, I kind of look at it in 3 different ways. I look at hormonal issues with our patient. Is that a problem? And then I look at I recommend an HSG, which is basically a test that looks at the fallopian tubes to see if they're open. And so that's kind of considered the plumbing in a sense to make sure that there's an open tract for the egg and the sperm to meet and for the embryo to move down the fallopian tube and implant into the uterus. And then the other part of it is actually the sperm, are there enough? Is there any problem with it? So actually, before I do consider it as part of the infertility workup, it is not everybody does that, but it is one of the tests that I do.
Okay, thank you so much. All right, continuing along. Next question here. What type of core exercises should be done to help with pelvic floor and delivery? What, if anything, should people with pelvic floor dysfunction do before getting pregnant, specifically when the pelvic muscles are tightened and contributing to constipation? Is it helpful to see a pelvic floor therapist if having pain during pregnancy?
Yeah, so pelvic floor physical therapists, I feel like, are on the rise. There's a lot more just general awareness about them, which is great. They are specially trained physical therapists in the pelvic floor, which are those muscles at the base of your pelvis surrounding the urethra, the vagina, and the anus. These muscles are really important for pregnancy, birth, and postpartum. And, I think the common exercise we hear about are Kegel exercises, but there are a lot of other important exercises that a pelvic floor PT can walk you through. It's actually just as important to know how to contract and activate these muscles when needed. And it's, equally important to know when to release and relax them when needed. So, I think there's kind of 2 ends of the spectrum. Some people struggle with an overactive pelvic floor. They may have difficulty relaxing these muscles, may have things like pelvic pain with intercourse or with exams, constipation or difficulty urinating. And then on the other end of the spectrum, people with kind of underactive pelvic floor muscles might have difficulty contracting these muscles. They might have urinary incontinence or leakage, or pelvic organ prolapse. So all of these things can be well treated by a pelvic floor PT. I recommend it to everyone, just for kind of a baseline to learn some of the exercises. It can be 1 or 2 sessions where you learn some exercises to then continue through pregnancy and postpartum. And then, they're really the go-to for specific conditions like pelvic pain, pain with intercourse, prolapse, bladder and bowel issues. So yeah, I think it's a great resource to know is out there.
Okay,
I'm just
thank
going
you.
to add that I think it's a great trend that pelvic floor physical therapy is a really expanding field. I remember back in the day when it was very difficult to find a pelvic floor physical therapist. People really weren't trained initially, and now it's really a growing field, as well as I think that our field, our obstetrics and gynecology, is getting better at utilizing them early on. I think that we used to tell our patients, oh, just yes, you're having some pelvic floor problems, but you know what? You just had a baby. You got to give yourself time. Just let it, got to give yourself time for your body to change back to not being pregnant anymore. And now I think that we're being a little bit smarter and sort of, encouraging earlier evaluations by the pelvic floor physical therapists. I think that it's a really good trend, and we're lucky that it's a growing field. I think also we used to tell our patients, just go do some Kegel exercises. And we sort of assumed, and I think many people assume they just know what Kegel exercises are. But when you go to a pelvic floor physical therapist, they really focus on like the proper focusing of which muscles. And it's not as simple as, it's nice to have like a very focused training of what muscles to use. So.
Absolutely. Okay, thank you. Dr. Coe, I have one more question for you here, kind of going back to our earlier discussion surrounding mental health, and then we'll just take a few more live questions and then wrap up for the evening. But quickly here, a question from the audience: will the change in hormones caused by pregnancy aggravate mental illnesses such as depression? And do you have any advice for managing mental health or depression when trying to conceive or pregnant?
So, pregnancy and the postpartum period as well, we really consider that a very vulnerable time in pregnancy for maternal health, mental health. Like you said, there are a lot of hormonal changes going on, a lot of physical changes going on, and oftentimes there are a lot of interpersonal changes going on, family dynamics, things like that. Being pregnant is such a major life event, and that involves so many other factors in a person's life. So when especially like certain things will increase the risk of maternal mental health issues, like previous history, if someone's had postpartum depression before, or history of depression or other mental health disorders before, that it really it does increase the risk of developing an exacerbation of the worsening of this problem during pregnancy and afterwards as well. I think that, in this day and age, we are getting better at trying to really screen for those risk factors all throughout pregnancy. I think that the term postpartum depression is a fairly well-known term and phenomenon now in the general public, but you know what, those things probably start very, very early on. So it is now very common for most obstetric people who provide obstetrical care to really screen for those things initially. So at that first prenatal visit that we've talked about, we should also add in there that most of us do some sort of type of screening for a mood disorder or some sort of depression risk factors. And then we often do it in the middle of the pregnancy as well. And as well, again, after delivery during that postpartum period as well. So we're starting to really acknowledge that that these are major issues that can start very, very early on.
And I wanted to add, it's also really, really common. We at our practice, we started a program called Healthy You, Healthy Baby, which is an application through the MyChart. And we started tracking the number of times women scored high on the depression screen. And our office staff was actually surprised at the number of women. And it's, I think, because we were asking the question, how are you feeling? How are you doing? And it's really common for pregnant persons to feel overwhelmed during the pregnancy. There's like the initial shock of being pregnant and your body's changing and you don't feel great. And you can kind of get sad about that. And then in the middle of the pregnancy, things are changing with your job and how you're feeling. Family pressures can play into that. So I just want to tell everybody that you're not alone. There's a lot of us who have these feelings, and please tell us at your visits that you're feeling this way. We have resources, we could help. And it's more common than we think.
Yeah, I also just want to plug postpartum.net, which is a great national website. It's not just on, again, on postpartum depression and anxiety. There's support groups, and you can find a therapist near you. So it's a great resource for mental health for anyone who's planning to be pregnant or postpartum.
Thank you all so much for that. Really helpful information there. Okay, we have one more question for tonight, and then we'll go ahead and wrap up the evening. This person here is wondering, and we've actually received 2 questions about this. If a pregnant person feels like their care is not enough from their current provider, how soon should they consider changing providers? How would you recommend going about this process? And maybe what would be the right questions to ask?
I think the first part of that question, how soon, is ideally as early as possible. Like if you've made the decision that you're looking to change over, or just explore a different provider, try to do it early on, because you don't want to be stuck in the position of, oh, now you're 36 weeks and very close to delivery, and it's a difficult step for both the patient and the clinician to take over about, the management of someone's care at that late stage in the game. So the first part of the question is, or as early as possible. As soon as, if you have any questions, or you're trying to explore other practices and other groups and other approaches, then I would recommend doing it as early as possible.
Yeah, I agree.
Okay, well, thank you.
What was, the second part was, I think, sort of what types of questions, right?
Any questions? Yep.
I think one important thing is to figure out, number one is, many people will choose, depending on where do you live, what's the closest hospital to you, what's the hospital that you're going to deliver at, or that you're planning on delivering at, and then from that list of OBGYN clinicians, midwives, and OBs, you sort of have to figure out, like, who are you going to go to. So I think the first thing is to figure out which hospital you're going to deliver, and sometimes that's kind of decided for you just because of where you live, right? You're not going to pick a hospital that's 2 hours away. You're hopefully going to pick one that's very reasonable for you to get to when you need to go urgently. And then some of the things that I think people should keep in mind is sort of what is that hospital's approach to deliveries? Who makes up the staff there? Is it only OBGYNs? Is it midwives who do collaborative care with their OBGYNs? And nowadays the trend is going in that direction. And I know that Abington does this, we do this, we have collaborative care, we have a team that consists of both certified nurse midwives and OBGYN physicians that work hand in hand to manage labor and delivery, and it works out very, very well. It gives our patients a really wide knowledge base to draw from, because you've got 2 very, broad-based, very well-trained people who are there to manage pregnancy, deliveries, and complications, things like that. So.
Thank you. Some important questions to think about and ask. So thank you. Okay, and we did receive a quick question. Are these providers taking new patients? So if you don't mind just letting us know if you're taking new patients, that would be great too.
Yes, we are. That'd be great.
All right. Perfect. Well, with that, I think I will go ahead and ask one last question of my own, and then we will go ahead and close out the evening. For the final question, what are your goals for everyone listening in on this webinar tonight? What do you want our viewers to take away from? And Dr. Martinez, we'll go ahead and start with you.
I want everybody to know that we are here for you. We want you to feel empowered. We want you to have knowledge. We want you to not feel scared. We want you to feel excited. And I think education helps with all of that, kind of knowing what's next, like what is the next step. And so I want you to use us, make an appointment. It could be in person, it could be telehealth, but really arm yourself with everything you need to get pregnant, to be pregnant, and then afterwards, we're there for you as well. The time before, during, and after pregnancy can be really exciting, hopeful, and anxiety provoking, confusing, and overwhelming, but you're not alone. We're there for you, and ask us questions, or just say, I don't know what to expect next, and we'll be there for you. We love to do this. We're in this long term because we love what we do, and we just want to make everybody's life a little bit better.
Well, thank you so much. All right, Dr. Ko, we'll turn to you. Any last remarks?
Yeah, I love what Dr. Martinez said. I will add on to there is no one right way to do this. It really, everybody's different. It depends on what your approach is, what your philosophy is. But we're here to support you, to guide you, to make suggestions for you, to make recommendations that are really tailored to your specific needs. We have a whole variety, our patients range from, some patients want to utilize all the available technology testing interventions, right? And then we have many patients who don't want to do anything that they deem as unnecessary or unimportant, right? And there's nothing wrong with either of those approaches. At the end of it all, we all have the same goal. Our same goal is healthy mom, healthy baby. There's no two paths to that goal that are exactly the same. And we're on this journey with you. It's never easy. I guess for some people it's easier than others, but I don't think it's ever completely easy. And there's things that are out of our control that we can't predict, but that's why we're here to help guide you through that and to be here for you when things are not ideal. And then hope, again, our goal in the end, healthy mom, healthy baby. So.
Yes, I love that. Healthy mom, healthy baby. Thank you. Okay, and Juliana, any last remarks to close us out?
Yeah, I reiterate all of that. I think that the fact that you all attended this tonight just shows how, you are already in the right mindset. I think that there's so many things that are out of our control in pregnancy, labor, birth. But one thing you do have control over is, feeling empowered to gain the knowledge that you need to be physically and mentally healthy going into this process. And at the end of the day, to trust the process, trust yourself, advocate for yourself and your needs, and find a healthcare provider that you can trust along the way. And yeah, I just thank everyone for being here tonight. This is so lovely.
Absolutely. Well, thank you, Dr. Martinez, Dr. Ko, and Juliana, for your time this evening. I know a lot of wonderful information was shared. I learned a ton, and thank you all for attending and submitting your questions. We will be posting an event survey, so you can let us know your thoughts, any other specialties you would like to hear from. Your feedback will bring more virtual events like this to you, the patients. And if you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please fill out the last question in the event survey. And be sure to visit jeffersonhealth.org to make an appointment. Stay up to date on upcoming events and webinars, just like this one and more. Please also visit jeffersonhealth.org/livingwell for more health content, patient stories, research, innovation, and much more. Be sure to also visit the Jefferson Health YouTube page to view more wellness webinar series events. We have various topics from back pain to robotic surgery to even the previous before the bump webinars. And a recording of this event will also be sent to you next week so you can rewatch at your convenience. And finally, here is a map of all of our Jefferson Health OB/GYN locations. If there is anything anyone here at Jefferson can do for you in this time of need, please reach out to us. Thank you once again for joining us, and please be sure to stay safe and healthy. Thank you all and have a wonderful evening.